tarda. Secretària General de la Universitat de Lleida, degà de la Facultat de Medicina, vicerectors, representant de la Universitat Ramon Llull, Doctors Light Family, digníssimes autoritats, benvinguts a aquest acte de determinació de cerimònia de doctor Honoris Causa al professor Richard Light. Hem estat convocats a l'acte solemne d'investidura com doctor Honoris Causa del professor Richard Light. Reconeixem amb aquest ritual solemne la trajectòria científica i professional al servei de la medicina, així com també la seva contribució al progrés i al benestar de les persones humanes. El doctor Light és un dels pneumòlegs amb més reconeixement internacional. Un prestigi, en primer lloc, fonamentat en la recerca clínica i bàsica, però també en gran generositat a l'hora d'impulsar grups de recerca, molts d'ells de països en vies de desenvolupament, una de les formes més eficaces i honestes de contribuir al desenvolupament. Des d'aquest punt de vista, em plau reconèixer el suport que sempre ha donat el grup d'investigació de Patologia Pleural de la nostra Facultat de Medicina. Em plau també assenyalar que amb aquesta investidura es fa dintre del marc d'un congrés sobre mesotelioma pleural. Així doncs, vull saludar de manera molt especial si hi ha algun congressista d'aquest congrés aquí. Vull assenyalar finalment que amb la incorporació del professor Light al nostre claustre de doctors i doctores, aquest s'enriqueix i li agraeixo, per tant, que hagi acceptat aquest homenatge. Tot seguit, la senyora Anna Romero, secretària general de la Universitat de Lleida, ens llegirà l'acte de nomenament del doctor Honoris Causa a la nostra universitat a favor del senyor Richard Light.
Benvolgudes senyores, benvolguts senyors, segons acord número 150/2009 del Consell de Govern de la Universitat de Lleida, reunit el proppassat 1 de juliol de 2009, s'aprova nomenar doctor Honoris Causa al senyor Richard Light.
Prego, doncs, el senyor José Manuel Porcel, padrí del doctorand, que faci entrar el senyor Richard Light. Dono la paraula al doctor José Manuel Porcel per tal que ens faci l'elogi dels mèrits del senyor Richard Light.
Distinguished Chancellor, Dean, members of the university community, colleagues, ladies and gentlemen. It is a great honor and privilege for me to present Professor Richard Light for the conferment of the degree of Doctor Honoris Causa by the University of Lleida. He is deserving of such an award for his human qualities and scientific contributions. Professor Light was born in the city of Steamboat Springs, Colorado in 1942. He graduated from the John Hopkins University Medical School in Baltimore, Maryland, and then completed the Internal Medicine and Pulmonary Diseases Training Program. Afterwards, he pursued an academic career at the Louisiana State University School of Medicine and became an outstanding clinician and teacher. In 1978, he was appointed Chief of Pulmonary Diseases at the Veterans Administration Medical Center in Long Beach, California, and Professor of Medicine at the University of California. In 1997, he obtained the degree of Professor Emeritus, which formally recognized his long academic association with the school. That same year, he changed his residence to Nashville, Tennessee, and took up his current position as Professor of Medicine at Vanderbilt University. Through his publication and lectures all over the world, Professor Light has become recognized as an authority in the field of pleural diseases. He has authored over 300 original manuscripts, which were published in the highest impact factor journals, including New England Journal of Medicine, Journal of the American Medical Association, Lancet, Annals of Internal Medicine, Blue Journal, Archive of Internal Medicine, Thorax, Chest, and many others. A great number of these publications have resulted from international collaborations with his fellows and friends, among which we are proud to be counted. The article by Professor Light, as written expression of his expertise, are highly regarded and extensively cited in the medical community. Professor Light's research has had an important impact in routine clinical practice. For example, his famous criteria, developed 38 years ago to discriminate transudate from exudate, are still the gold standard and a pragmatic first step when confronting a patient with a pleural effusion. In 1995, he also devised an original classification of parapneumonic effusions based on the presence of bad prognostic factors, which has had important implications in making therapeutic decisions. An additional invaluable contribution of Professor Light relates to the development of animal models to study malignant and infectious effusions, as well as the mechanism of pleural disease for a number of different sclerosing agents. The role of a myriad of pleural fluid tests, the natural history of pleural effusions occurring after coronary bypass graft surgery, of the use of indwelling catheter for the outpatient management of malignant pleural effusions, are also on the list of his research achievements. Professor Light's most renowned book, Pleural Diseases, was first published in 1983 and is now in its 5th edition. It is considered the Bible of all physicians and researchers looking for information on this subject. Moreover, he has co-edited an equally notable textbook of pleural diseases, which recently won the Respiratory Medicine First Place at the prestigious British Medical Association Books Award. From 1994 until now, Professor Light has been the author of the chapter on pleural diseases in Harrison's, the most famous textbooks of internal medicine. Professor Light has served on the editorial board of numerous international journals. He is currently the section editor for Disease of the Pleura in Current Opinion in Pulmonary Medicine, and also the editor of the International Pleural Newsletter. It would take too much time to list all the committees or international advisory bodies where he has functioned as a chairman or member. It's little wonder Professor Light has received prestigious awards from the American College of Chest Physicians and the American Thoracic Society. There have been few clinicians, if any, who have contributed so much to our understanding of pleural diseases worldwide. Fortunately for me, Professor Light, our path crossed some 10 years ago. Not only have I personally witnessed your rigor and integrity in research, but I've also been impressed by your worth and extraordinary sincere personality, the qualities of which cannot be measured by citation analysis as were your publications. For all these reasons, Honoris Chancellor, it is with great pleasure that I present to you, for admission to the degree of Doctor Honoris Causa, Professor Richard Wayne Light.
Bé, ara demano a tots els assistents que es posin dempeus per tal d'iniciar el solemne acte d'investidura d'Honoris Causa, and I ask Professor Light to come here. Okay, come here. Pel claustre de la Universitat de Lleida i com a homenatge als vostres mèrits rellevants, heu estat nomenat doctor honoris causa d'aquesta universitat. Per l'autoritat que m'ha estat donada, us lliuro a l'esmentat títol i us imposo com a símbol el bitllet birret llorejat, distintiu venerat al nostre més alt magisteri. Porteu-lo per coronar els vostres estudis i mereixements. Rebeu també l'anell dels antics lliuraven en aquesta vella cerimònia com a emblema de privilegi que s'atorgava de signar i segellar dictàmens, consultes i censures que pertonquessin a la vostra ciència i professió. I també els guants blancs, símbol de la puresa que han de conservar les vostres mans i que de la mateixa manera que l'anell són també signe de la vostra dignitat. Incorporat ja al nostre claustre, rebeu ara, doctor, en nom de tots els claustrals, una abraçada de fraternitat dels que s'honoren i es congratulen a ser els vostres germans i companys. Bé, podem seure. I ask Dr. Light if you could pronounce your speech or sentence being part of our university.
Thank you.
Jo crec que sí, ho creiem perquè fa calor, no?
Buenas tardes. Chancellor, Dean, faculty members of Lleida University, I am very honored to be here. Es a gran honor para mí recibir el grado de Doctor Honoris Causa de la Universidad de Lleida, particularmente porque es la universidad más antigua de Cataluña. Gracias, José Porcel, para mi nomination. No more Spanish. Sorry. I would like to tell you the story behind Light's criteria. And for a little background, a patient who has fluid between their lung and their chest wall is said to have a pleural effusion. The fluid comprising the pleural effusion is called pleural fluid. And there are basically two types of pleural fluid. One type occurs from local factors in the chest, and it is called an exudate, while the other type occurs from systemic factors such as heart failure and is called a transudate. I developed a method to distinguish transudates from exudates almost 40 years ago. Dr. Purcell has mentioned that. This method is called Light's criteria. And what I will tell you about now is how Light's criteria came into being. When I was an intern in medicine at Johns Hopkins Hospital in Baltimore, Maryland, in 1968, 1969, there was a period where I had a large percentage of patients that had pleural effusions. The chief resident, Dr. Richard Winterbauer, would make rounds about midnight every night and would always ask me if I had sampled the pleural fluid and what were the results of the laboratory tests on the fluid. At that time, the only thing we would routinely measure was the cell count in the differential, the glucose, the protein, and we would do smears and cultures on the pleural fluid to see if an infection was present. I would do these things, and then I would ask Dr. Winterbauer the significance of the various pleural fluid findings, and for the most part, he had no answer. It was about this time that additional measurements were being made on blood, such as lactic acid dehydrogenase, the SGOT, the SGPT. And about the same time, blood gas machines became available that would allow one to accurately measure the degree of acidity, the pH, and the levels of carbon dioxide and oxygen in body fluids. I theorized that some of these new measurements might be useful in the differential diagnosis of pleural effusions, as there are many different causes of pleural effusions. After doing a literature review, I developed two hypotheses. The first was that the pH, the acidity of the pleural fluid, would be lower in tuberculous pleural effusions than in other exudative pleural effusions. The basis for this hypothesis was an article in the Scandinavian Journal of Respiratory Disease that purported to show this. My second hypothesis was that LDH isoenzymes would be useful in the differential diagnosis of exudative pleural effusions. There are five types of LDH, and these are called isoenzymes. In order to get the absolute value of the LDH isoenzymes, I needed to have the total protein in the pleural fluid and the serum. A previous study on pleural fluid LDH had concluded that the pleural fluid LDH was elevated in malignant pleural effusions compared with other exudative pleural effusions, such as pneumonic effusions or tuberculosis. I submitted my protocol to the Institutional Review Board at Johns Hopkins and received their approval. I made the following arrangements to obtain the various tests. The blood gas machine was in the pulmonary function laboratory, so I could measure all the pleural fluid blood gases myself. The clinical laboratory would measure the protein, the LDH, and the glucose in the serum and the pleural fluid without charge. However, I did have to come up with funds to pay for the LDH isoenzymes. And I received a small grant from Johns Hopkins Hospital to do this. Now, in order to get called when patients with pleural effusions were admitted to the hospital, I made a deal with my fellow interns and residents. If they would call me when they sampled the pleural fluid with the thoracentesis, I would do the cell count and the differential on the pleural fluid. These were duties for which they would normally be responsible. I lived across the street from the hospital, and I found out in a hurry that with this arrangement, I got called often in the middle of the night when people were sampling the pleural fluid. The study did not start well. One of the first patients I studied was a young man with an exudative lymphocytic pleural effusion. His pleural fluid pH was 7.4, which is normal. The patient turned out to have caseating granulomas on the needle biopsy of the pleura, which is diagnostic of tuberculosis. So much for the first hypothesis, that one could diagnose pleural tuberculosis by a low pleural fluid pH. Shortly thereafter, another patient had a pleural fluid pH, and this pH was 6.95, very low. The pleural fluid was clear yellow, and the pleural fluid glucose was not reduced. However, the pleural fluid grew streptococcus pneumonia, and the patient eventually developed a frank pneumococcal empyema with pus in his pleural space. This was the first case that suggested that a low pleural fluid pH might be an indicator that a pleural effusion associated with pneumonia would need drainage of the pleural fluid. Over a 2-year period, I studied 150 pleural effusions. I submitted an abstract of my preliminary findings to the American Thoracic Society for their annual meeting in 1971. The abstract was rejected. I was devastated. In early 1972, Johns Hopkins had a reunion for some of their alumni so they could get money from the alumni. My mentor, Dr. Wilmot C. Ball, suggested I present something on pleural fluids that I had been studying. At that time, transudates and exudates were usually separated by using a protein level of 3.0 grams. I elected to see how this would work on my set of pleural effusions. On one rainy, sleety Sunday in Baltimore, Maryland, I spent several hours with a pencil and graph paper plotting the protein levels, the LDH ratios, and the ratios of the pleural fluid protein to the serum protein, the ratios of the pleural fluid LDH to the serum LDH. When I examined my plots, it was obvious that no single value of any of these measurements correctly identified all transudates and exudates. If the cutoff was made high enough so that all transudates were below the cutoff level, then some exudates would be classified as transudates. Now, my objective at that time was to identify all exudates correctly. Therefore, I elected to make the cutoff points so that no transudates were above the cutoff level. I noticed that when I did this, some exudates were in the transudated range for each of the measurements. However, I also noticed that if you use 3 different cutoff levels, such that no transudates were above the cutoff line, one could identify almost all transudates and exudates correctly. The 3 cutoff points that I found were a pleural fluid serum protein ratio greater than 0.6, pleural fluid serum LDH ratio greater than 0.6, and an absolute pleural fluid LDH greater than 2/3 the upper normal limit for serum. An exudative pleural effusion met at least one of these criteria, while a transudative effusion met none. I presented this data to the alumni, and they didn't seem very impressed. I also submitted an abstract on the separation of transudates and exudates by the above criteria to the American College of Chest Physicians in 1972. It was accepted for an oral presentation in Atlantic City. This was the only oral presentation that I ever participated in where the audience graded the contents of the presentation. I got at most average marks. Certainly nothing to suggest that these cutoff levels would still be in use almost 40 years later. Nevertheless, I wrote the paper and I submitted it to the Annals of Internal Medicine. There it was accepted with minimal change. Now, this method of separating transudates and exudates was first referenced as Light's criteria in 1989, 17 years after the original paper. Even though this method of separating transudates and exudates was used extensively in the intervening 17 years. Since the original publication in 1972, there have been many studies comparing other measurements to Light's criteria for the separation of transudates and exudates. But in general, Light's criteria have been proven to be better than anything else. I am absolutely amazed that after 18 years, Light's criteria, after 38 years, Light's criteria are still being used. Now, I believe there are several lessons to be learned from my experience in developing Light's criteria. First, if you want people to cooperate with you on your research, you need to make it worthwhile for them. In this case, I did some of the work that the other interns and residents would have to do, so they would call me. Second, although research is best done when it's hypothesis-driven, it's worthwhile to look at your data to determine if there are ancillary findings outside of your main hypothesis. Because my main hypothesis didn't work very well. And I certainly did not have a hypothesis about transudates and exudates. From this study overall, I wrote 5 papers. Light's criteria, which the talk is about. Another paper on the usefulness of glucose and amylase in pleural effusions. Another one on the cells, the differential cell counts in pleural fluid. Another on the diagnostic usefulness of pleural fluid pH. And the last one on the LDH isoenzymes in the pleural fluid. This was the second hypothesis. And this was the weakest paper of the 5 papers I wrote as a result of the research. Now, third, if you're a researcher and you initially submit your work and it is not particularly well received, do not give up. Remember, the first abstract on Light's criteria was turned down. So some very good work gets turned down the first time it is submitted. Fourth, it is much better to be lucky than to be smart. It did not take a genius IQ to sit down and make the plots of the proteins and the LDHs. And fifth, meaningful research need not be unduly complicated. I have now written more than 400 papers, and the one dealing with Light's criteria is probably the simplest of the papers, but it is the one that made me the most famous. Keep it simple is one of my mottos, and I think when you write a grant or anything else, this is good advice. So I would like to thank you for your attention. I again would like to thank Dr. Porcel for nominating me for this award. He said, I was I forget exactly, one of the masters in pleural disease right now. I fully expect Dr. Porcel to take my place as a master in pleural disease over the next 10 years, if he is not already a master in pleural disease. Thank you very much for your attention.
Senyores i senyors, la importància i el valor que la universitat dona a aquest nomenament, el més alt honor d'aquesta institució concedeix, es posa de manifest en la solemnitat d'aquest acte marcat per un ritual antic i d'un alt valor simbòlic. I ara, si de cas, ho diré en anglès, vosaltres perquè també se'n puguin enterar. The importance and value that the university gives to this appointment, the highest honor granted by this institution, is revealed in this solemn ceremony by an ancient ritual and a high symbolic value. Lleida University is one of the oldest universities in the world, created by King James II and the Pope Bonifacius VIII in the 13th century. It was renovated since 1991 and became a modern university. Over recent years, the University of Lleida has awarded this honor to few personalities all over the world, and they have excelled in different branches of knowledge in order to honor them, and consequently is it an honor for us. Today, with this doctorate, Lleida University wishes to acknowledge the contribution of a man that dedicated his whole life to medicine and to fight between quality of life, for better quality of life of humankind. We also know that with this honor given to him, we gain a supporter, and we shall benefit from his wisdom and his humanity. Thank you very much, Professor Porcel, for your excellent laudatio of Professor Light, one of the most international known pulmonologists whose contribution to the knowledge of diseases of the pleura. He is, we could see, a complete scientist, a physician interested for his patients. From the bedside, he finds the question that he brings to the laboratory, combining clinical and basic research for high quality in one specific area, the diseases of the pleura, but also in other aspects of respiratory medicine. He gained a deserved prestige. That's the reason why today it is difficult to find an international medical conference content in pleura's disease without the participation of Dr. Light. He has lectured in over 40 different countries, and his particular charisma has provided countless friends who has worked with him in clinical research. He is also sensible towards developing countries, and he helped them to improve their clinical work. Also, we must thank Dr. Light for his ability to enhance foreign groups interested in pleural disease, which was served as a mentor. In particular, I must thank his help to Lleida Research Group in pleural disease. Each patient teaches the doctor if he or she is capable to know it. Each diagnosis and treatment is a process of research, and each patient can and shall draw conclusions for others. We learn from successes and from failures. But for this to happen, it is necessary to be mentally prepared for this learning and research, to have the knowledge to do it, know the methods of research, and to be humble. The doctor is not only a scientist hidden behind a medical device or a computer. To be a competent doctor, it is necessary to be a good person, a humanist. For me, some famous TV series draws a model of doctor that is not a good doctor, even he is right with the diagnosis. Patients need to be treated as human beings, and doctors must be sensible to their problems and fears, and have empathy with them. In medical school, we must prepare medical students to acquire those competencies, and for that it is necessary to develop their emotional intelligence. In our medical school, we try to teach our students to become good physicians, with competencies based in knowledge, skills, and those human attitudes. Your books for further light are part of the references for pleural and pulmonary diseases. Congratulations, Professor Richard Light, for your life dedicated to medicine and for all your success. Thank you for accepting the honor to become Doctor Honoris Causa of Lleida University. Today, our university incorporates to our faculty men from science, but also from humanities. These are, ladies and gentlemen, aquestes són, senyores i senyors, els arguments que tenia el Consell de Govern de la nostra universitat quan per acord unànim va decidir incorporar el claustre de doctors tan il·lustre professor. La Universitat de Lleida es beneficiarà del seu saber i al mateix temps tindrà un nou valedor arreu del món. Per això, en nom de la comunitat universitària, li dono les gràcies. Moltes gràcies. Thank you very much. I ara jo demano als assistents que es posem de tots dempeus pel cant del Gaudeamus Igitur. A una copa de cava al bar de la Planta.